And with that, I will say hello again. Good evening, everyone. I am Maria Pepe, Community Engagement Director for Empath Health. I have the privilege and honor of leading our Community Partnership Specialist team under the Diversity, Equity, and Inclusion Department of this great organization. We want to say thank you for joining us tonight. As I mentioned, and you heard from your liaisons or community partnership specialists, or those who invited you tonight, the Hospice and Palliative Care Organization has selected Courageous Conversation as the theme to honor November, which is the National Hospice and Palliative Care Month. So welcome to tonight's webinar. Thank you for being here. Feel free again to use the chat feature. We are starting just like that with a conversation. So if you have any questions, you can put them on the chat. We will ask our wonderful panelists as we go or at the end. For those that will be seeing the recording, thank you so much. We missed you during the live presentation, but we are very appreciative that you're taking the time to join us and hear from some of our lived experiences and tidbits that we might want to share regarding courageous conversation, end-of-life care, hospice, and palliative care. So with us today, we have a very powerful panel. Like many of our colleagues, we share a great passion for what we do, the communities that we serve. So it is my pleasure and honor to introduce you to our wonderful panelist, Dr. Jasmin Jerez-Marte. She is one of our medical directors, currently directing a Coral team, Orange team. Dr. Jerez-Marte, tell me all the teams that you're currently overseeing.
No, I'm the purple team doctor officially.
Purple,
among other things, but that's my team.
I cannot get the colors right. So purple team. And also with us, Dr. Vilma Hernandez. Vilma, she is one of the clinicians with Empath Health Grief Care Program. She is at the Brandon office. And also we have Jim Andrews, the one and only Jim Andrews. Jim is our Director of Spiritual Care for Empath Health Hospice Division. So welcome and thank you for being here. So we're going to start with our questions. And I would like to start with Jim. So Jim, as I mentioned, the National Hospice and Palliative Care Organization selected Courageous Conversation as the theme for November to honor National Hospice and Palliative Care Month. So what are your thoughts on why will it take courage to have conversations related to our health or the lack thereof?
That's a good point, Maria. I mean, what's so hard about it, right? We're just sharing information. But here's the thing. It's one thing to consider these topics in the abstract. It's a whole other thing when the information being shared and the decisions that need to be made are about you or somebody you love. Then there are multiple layers of complexity, which make navigating these conversations well extremely difficult. And that level of discomfort too, it isn't just with the patient and family. Sometimes it's often with the person initiating the conversation as well. So let me just think of a couple of things, some of the barriers from the professional point of view and from the point of view of the patient. So for the professional, these can be challenging conversations to have because, well, no one wants to be the bearer of bad news. And so when you're having difficult conversations, it's very tempting to soft pedal or use euphemisms or not share the complete picture because you don't want to be the one that shared challenging news. The professional can also anticipate the emotional response of the people that she or he is talking to, and that can feel overwhelming and anxiety producing for them. They may not feel like they have a good enough grasp on the knowledge that's involved in the information that they're sharing or the options that are available to them, or may not have that confidence level in having those in-depth conversations. They might have a challenging time establishing a comfortable and trusting connection with the patient and family to where they can share information freely and know that it's being received. They might have difficulty managing their own emotions and keeping the focus on the patient and family when they see how the news that they're talking to these folks are impacting them. And also, we can feel like we don't want to be the one that causes the patient and family to lose hope or to become depressed or despondent. And so these are just a few of the reasons why it can be challenging for a professional. So if you switch sides now and you think about it from the standpoint of a patient or a family, these conversations can be challenging because, well, I don't know about you, but I think it's just difficult to process medical information and fully understand it and all the ramifications of it in the moment. I know even from my doctor's appointment, I have to unpack everything the doctor said. And then I always think, oh, I wish I'd asked about that, or I wish I'd said that or shared that. So it's difficult to process. When we get challenging news, we may experience denial. It's a natural reaction to push back emotionally and think, surely it's not so. Maybe there's a cure. Maybe they got the test wrong. Should I get a second opinion? We may have a mistrust of the healthcare system. There may be reasons, personal and societal, that were well-founded, where we don't really trust the healthcare system to have our best interest at heart. It may be that in your culture, in my culture, it's not really appropriate to have these conversations, and so you're kind of creating a faux pas just by introducing the topic. Or this information may precipitate emotional or spiritual crises that cause us to just shut down and not be able to engage and process what's happening effectively. So these conversations aren't just about relaying information. They're much more complex than that. And it takes training and practice to develop these skills needed to effectively guide patients and families through these discussions. And yes, it takes courage. It takes courage because it means that you have to lean in to conversations that almost everyone else is trying their best to avoid.
Absolutely, Jim. And again, thanking all our audience today, because with us today, we have our supporters, our ambassadors, as we call them, our advisory councils. These are community members that continuously meet with us, give us ideas, and bring our message out to the community. But how is our comfort level, even for us, our passionate, dedicated team of community partnership specialists? This is something that we don't take lightly. We understand that this is no 1, 2, 3, this is how you do it. Go out in the community and have this courageous conversation. These are skills that we're constantly developing. We're learning from our advisory councils present at this webinar tonight, the ones that are going to be joining soon, watching the watch parties. We're learning from each other, from lived experiences, and we're also learning from you, Jim, Dr. Jerez-Marte, Vilma, and our patients and families. So, Jim, following up with that, I wanted you to tell me, so people sometimes may look at us as end-of-life care providers, as, well, our standards are even higher. The conversations that we're having with communities, that we're having with families, with individuals are, at that level of vulnerability. So are there things that you tell yourself, you remind yourself before you enter into that space to make sure that you are creating that sacred moment where you can have a courageous conversation, yet compassionate at the same time.
Think you're muted.
You're on mute.
Thank you. What a great, isn't that the most popular phrase in the world right now? You're on mute. And you never want to be the one that they're saying that about, but oh well, I've done my time here. So I was just saying, what a great question, Maria, because I do feel like even for somebody who's had conversations like this before, some mental and spiritual preparation for them before you enter into them really is important. It's key to making that work. And so some of the things that I think about and tell myself are, first of all, and perhaps most importantly, this isn't about me. This is not about me. There's a hospice professional that's coined the term empathic over-arousal. If we over-identify with the pain that a patient and family is feeling, that can be the enemy of compassionate connection, because then we become caught up in our own feelings and are unable to focus on the needs of the family. So, and I'm an empathic person, and when I see somebody who's suffering or is experiencing emotional or spiritual pain, my heart goes out to them. And so I have to remind myself to keep my focus on them and not about my feelings about what they're going through. So that's kind of a tightrope, but you want to be a compassionate presence, but you don't want to over-identify with their pain and make yourself incapable of making that compassionate connection. Secondly, I feel like we need to recognize that it may take time to process some of this stuff, and we may need to have more than one conversation, and to recognize that there are windows of opportunities when patients and families experience an increased level of openness to having these conversations. Also, I feel like we have to meet them where they are. I mean, there are ways to have conversations about these things, even with people who have not fully accepted the reality of a diagnosis or a prognosis, and we can affirm that for them. We don't need to convince them of anything to have these conversations. I also think it's key that we honor their cultural and religious beliefs and customs, that we educate ourselves about them, that we engage in respectful curiosity about those things so that we can make sure that we are truly meeting them at their point of need and providing them with the resources that will help them navigate this difficult time. I also think I have to remind myself to keep my goals straight. I'm not there to check off a list of something on my to-do list, or I'm not there to get a document signed. I'm there to assist the patient and family in processing information and accessing their values to make complicated decisions that will profoundly impact their living and their dying. And so I have to make sure I keep my goals straight. And lastly, I think you have to accept that not everyone you talk to is going to be willing or able to really engage with you on these topics, and know when to nudge and when not to nudge, because we can only take people to areas where they're willing to go. So those are a couple of the things that I remind myself of.
And Maria, if you don't mind me jumping in that little last piece that Jim mentioned, is not by chance that the Dana-Farber Cancer Institute has a very popular difficult conversations guide. The first step is to assess, is the person that you are trying to have this conversation ready for the conversation at the moment that you're showing up? How much do they know, and how much do they want to know or to have disclosed during that conversation? And I think that is so essential, is so compassionate, is so courageous, because it may mean that you may be turned down at that moment, and you're gonna have to deal with that. But again, if we're having these conversations and not making them about us, but about the person we're trying to reach, it's important to always respect that space and make sure that they're ready to listen to what you're going to have to discuss at that time.
So I thank you for that, Jim and Dr. Jerez-Marte. This is so fitting for all stages in life, because when we're talking about patients and their families and diagnoses, I'm thinking about a friend going through a divorce or in a difficult relationship, someone who has lost their job, a house to a fire, somebody who is going through a difficult time in their life, and we want to be there, or we might want to approach and have a conversation. All these things apply because it's about how do I remove myself and understand what is that other person needs from me at this moment. And it's about setting those parameters that I'm learning right now, if I can paraphrase, how much does the person know and how much they want to know, where they are right now. So meeting them where they are. So thank you. And let me go with you for a second, Dr. Jerez-Marte. So I have had the honor of working alongside with you and learning from you as we have assisted families during difficult situations, having difficult conversations, helping them participate in a plan of care, as we call it in hospice care, making sure that the families and the loved ones, people important in the life of that family, that individual, are involved in the conversations of their plan of care. So I want to ask you the same question that I asked Jim. What are those things that you remind yourself, in addition to those things that you just shared from the Cancer Center? What are those things that you remind yourself before you enter into that room, before you enter into their space, to ensure that you are creating a safe environment for those conversations?
I'm going to steal the answer. So the NHPCO was conducting certain interviews and posting them to hospice providers and palliative care providers about what they thought a courageous conversation meant or was. And Kristen Williams, I hope I got her name right, is the VP of hospice in Chesapeake Bay. And her answer was a one-word loaded answer. And it says, a courageous conversation is vulnerability. And then you're like, oh, okay. Let's unpack that, right? So you have to be vulnerable as the patient, bringing up this courageous and difficult conversation, and create that vulnerable environment, which I'm sure Vilma is an expert, where you allow others to show that vulnerability, which may not be their forte. They may not be used to it either. So what is to be vulnerable is just to, show up as yourself and understanding any shortcomings. And that may be, I may be a little bit over empathetic. Let me check that on the door before I come and start this meeting. I may have an agenda because we need to, have a whole team telling me that we need to talk to this patient that is sitting in this hospital bed and they don't want to make a decision, and I'm going to call you to come and fix that. All of that, you have it in your mind, but you need to recognize that that may not serve you at the moment of having that conversation. So opening a vulnerable environment when you as a person having the discussion and bringing the discussion up, as well as the patient, family, or friend that you're talking to, allowing them to be able to open and express their need. And another thing that I always bring to my mind when having these conversations, and I have told Jim before, when I'm dealing with difficult team meetings where we may not be agreeing on something, I said, my mantra is like, go in there, prepared to be changed by what others have to say. And I repeat that several times. It really calms me down and puts the right frame so that I can listen, and then start forming opinions, and then start maybe collaborating. It's very different when you go and talk to somebody about something really difficult that is affecting them, and you already have an agenda, and you have this preconception of what they should be answering and the choices that they should be making. Is very different than when you show up waiting to hear what they want, what choices they want to make, even if they're still asking you for your opinion on what you think they should be making. So being open to that.
I second Jim's heart. So I'm loving all these answers. And again, as community engagement, we meet with people in many cases way before they have to be making these decisions or having these moments and crises and conversations. So this is why we value having these opportunities, educational opportunities, because we can be talking about these things before crises arrive. So something is getting planted there for all of us to remember, this might not be an end-of-life conversation with a patient, or it may be. Sometimes when we work in social services, we're serving people that may come to us and say, hey, my loved one have been in and out of the hospital for the past so many months, so many days, and I don't even know how to bring it up that they may need help. So this is a reason why we're gathering here. And talking about looking for guidance when having these conversations, Dr. Jerez-Marte, some of the reasons that you and I have collaborated in the past is because a little bit of that, hey, we have this Latino Hispanic family that are having difficulty coming up with a plan of care, or they might have a lot of questions, and sometimes family calling from overseas. We have the large families and the families that only have 2 people for each other. That's it. So you and I have worked together in some cases. So I have, again, in my continuous learning from you and our colleagues, tell me, how do you implement your cultural awareness, your cultural curiosity when working with patients and families, or patients and the important people in their lives of diverse backgrounds?
That's great. And I was recently working with a family where I had to really dig into that cultural awareness and to help me understand why the decisions that were being made. And it was the case of a daughter whose mother had advanced dementia, was in the hospital, clearly with severe pain, went through a surgery, and the daughter was preventing the staff from medicating mother for pain. And she would allow certain things very mild, but not what the staff thought would be more sufficient to control her pain. And then, just digging a little bit more in the background, what was their upbringing? How did mom react when other family members were sick and she was the decision maker for them, if that was the case, right? Because there was a father no longer alive. Her mom had to go through caring for that person when they were ill and dying. So there's a lot of learned behaviors, but also cultural behaviors as of why we would not want to, perhaps hasten death, which a lot of people have a misconception that pain medications will hasten death. So understanding, and not understanding cultural background as a monolith where, okay, well, they're Hispanic, this is how they work, they're Muslims, totally get it. You will be surprised within the same groups, the many different answers that you will get to how people deal with critical situations. So I think opening the conversation a little bit more about the background, their understanding, what have been their personal lived experiences. And another thing that I find helpful, for example, very often we find out that there are families and communities that mom and dad just take a back seat, and it's understood that after a certain point in their lives, their children are the ones that are going to be making decisions for them. They don't even want to answer you talking to them, and they're pointing at their children. They are the ones that are decision making. You're like, but I don't have a healthcare surrogate paper, but this person's not even listed in the chart. But all of them are the people who the person in front of you wants to be collaborating to make decisions for them. So all of that is acceptable and well, and we need to understand it, and we need to tap into that to gain trust so that we can help them navigate a good answer for their loved one.
Thank you for that. Brought me memories. Professional lived experiences and personal lived experiences. Yes. So this is how we learn. Thank you so much, Dr. Jerez-Marte. Vilma, I believe you have so much to add to that because as a licensed counselor, clinician, you interact with a lot of families. And so I wanted to ask you this. In your practice, Vilma, you probably see a lot of individuals that you're like, oh, if I could help with the communication to happen, to take place. People that are struggling, bringing up difficult topics or having conversations with people in their lives about things that, they want to solve. Tell me some of the things that you may suggest to an individual to overcome those barriers that stopped us from communicating.
Yeah, so I am going to piggyback. A lot of the answer was just given by Jim and Jasmin, because one of the things that happens is that we're not the expert on that client's family. They are the expert on that family. And so we don't really have to, every time somebody comes into the office, it's a brand new world. It's a brand new world of generations and generations. We talked about family culture. We talked about the way they see the world. And so every time is you are an amateur learning from them who they are, what they value, what they don't value. Obviously, in the general macro sense, I'm going to say this because I say this speech all over and over again, but I feel that as a community, as a society, we need to be talking about death and dying early in our lives, when we're healthy, when we're good, when we're in our 20s. As soon as a person turns 18, we should talk about, a medical surrogate. If something happens to you, who do you want that decision to be made? A lot of what I see is people that have been together, living together for 20, 30 years, but they never signed a paper. Nothing was done. And then they are removed from that ability. And they're saying, but that's not what he wanted. That's not what she wanted. But somebody else is making that decision because no paper was ever done, And as a society, we all say it in general sense without really meaning it. Like, oh, we know life is transitory and we know we live and we die. But generally, we really don't talk about it, It's not a fun conversation, but really, anybody that turns over 18 and we get a license and you're a mature person, start thinking about a medical surrogate, start thinking about a living will, in general. So once we educate that it is okay to talk about that it is okay for all of us in the room to have one done, if somebody doesn't have it done, we should have it done, right now, so that it doesn't become later on. I work a lot with caregivers. Caregivers who are at a loss of what to do or where to go from here, because it's very painful to think about your loved one dying, but you see them declining, and nothing is done. So how do you open those conversations? It's exactly about what we talked about. Learn about the world, learn about who they are, what they value. And little by little, we need to be comfortable with words like medical surrogate, like, it is important. So have, your loved one done a paper, on a living will. And so they're like, what is that? You start the conversation kind of like in the general, if that helps, this is what is out there. so that we began focus on what they need. Absolutely, siblings are always, not always, but most of the time, they're in conflict of what they want for their father or their mother, and they don't have a way to have a conversation without the pain that is involved in all of this. And so providing a space, a safe space to really talk about it, to let them, each of them express, because even though they come from the same family, we have different philosophies, different views. You were speaking about that, the difference in the Latino population. There is no one family alike like the other, not only because we're 35 countries, but there is really not one family that we can say, this is what we value. And so even inside a family, we have different religions and ergo different beliefs, of what to do with our loved one when that happens. One of the things is that if we feel comfortable understanding that we don't know anything about that other person, that we don't know anything about them, then as they let us into their world, then you see those, open windows that Jim and Jasmin were talking about. The open windows where, oh, I can interject this, oh, I can say this, or this is the time for me to say this in general. But it is about listening. I would say it's 80% about listening. Once you get that, once you build a rapport, it's actually easier, my job, I think, in the sense that when a person comes into the session, is what brought you here? Why are you here? And it becomes about them immediately. One of the things that I do want to echo Jim and Jasmin in what they were saying is, we cannot have empathy, we cannot have compassion unless we have good boundaries. And if ever I work with my clinician, my supervisors, is developing good boundaries, so that they can be empathetic, so that they can be compassionate. Not only because we want to prevent burnout, but because we do a better job once we understand that this is their world and this is about them. I don't know if that helps.
Oh, it helps a lot because you brought us a lot of good reminders, many good reminders, Vilma. Thank you. And you summarized some of these conversations as we're having, meaning there is no do's and don'ts, quick fix, we're ready to go. Let's have courageous conversation about difficult topics. This is something that we learn with time. Go ahead.
No, and it's something that I want to echo what they said, because you have to have the same conversation several times.
Mhm.
I always say, well, I'm pretty dumb and I have to hear things 3-4 times, so I know we talked about this 2 weeks ago, but let's bring it up again now, or I know we talked about this a month ago, but let's bring it up now when I see the opportunity, because the second time they go, oh yeah, and the third time they ask more questions, and the fourth time they really know. So it actually takes us, because it's difficult, one of the things is, as we support the caregivers, as we honor them, as we respect them, as Jim and Jasmin said, we respect who they are, and they feel our support, they will open up their world to any, and unfortunately, I know that in hospice care, by the time they refer to hospices at the very end, which is like, makes it more difficult,
And to your point, Vilma, okay, my sister-in-law, it takes her at least 6 to 8 hours to choose a pair of shoes, because she always thinks there's going to be a more comfortable one. I'm going to get it at a better deal. And she goes to multiple stores and agonizes over buying a pair of shoes, and so how much more time does it take to really process all the angles when you're talking about decisions that could impact your life so profoundly and the lives of those you love? And also, I think we've got this Instagram culture now where everybody's fine, everybody's thriving, and it makes it even more difficult to talk about your vulnerable spots, And I remember I was doing a training on with a class of people who were going to do advanced directives with patients and families. All those people were being trained to have these conversations. And at the beginning, I said, I'm a chaplain, so you have to tell me the truth. How many of you have advanced directives? and out of a class of 35, 2 people raised their hand. We don't want to talk about these things.
Mhm.
And so it really requires a lot of skill to engage people with these topics. They're difficult.
You know what, Jim?
Mhm.
I've started the habit of showing up with our form for healthcare surrogate and living will. When I go to do our presentations, I often go to the hospitals and do, staff meeting physicians. And I just leave the stack up front and mention that it's there and give some instructions how to fill it out. And inevitably, you see a few people taking a few copies. Some may come to me, but it's amazing amongst healthcare providers, community, providers like in this group, that we may hear about this topic over and over again. We may talk about it over and over again. The last person to address, and I love Vilma's idea. It's like, as soon as you get a driver's license, fill out a healthcare surrogate. It has so many nuances. I'm actually, for Christmas, I started mailing a few of those to certain family members after having the discussion with them, of course. But this Christmas, I'm going to ambush my family because we're going to spend 3 or 4 days together, and I'm going to bring a stack. And just like in my meetings, I'm just going to put it in the kitchen and then make some reference to see if I have some takers. But it's so important.
One of the, I know I shared this earlier and they asked me to share it again. So I'm going to talk about this one specific family. There were about 4 adult siblings who didn't know how to bring up the conversation with the mother who was developing dementia. She had moments of clarity. And so I said, okay, let's all come together when all of them were together. Then I brought up all the forms for everybody, and so then I started talking, this is what it formed is, this is what this other one, do you have it? And so they were like, no. It was interesting how they all were able to fill it out, and mom didn't feel targeted, it's a way that we can do as a family, what do you want to happen? And there were interesting things that happened within that family, and I'll never forget that session, because, the brothers were like, oh, you want to do that? Oh, I want to do that too. I never even thought about that. And so it is about a way to be able to have these conversations in a way that it is not, we don't have to wait till the end. I think that your jobs would be so much easier if these conversations was already done. They've been signed 10 years ago, 20 years ago, and by the time we come in, we just help them through, but to begin the conversation when it's at the end, it's like, who's making the decision, and on top of that, we are in the moment where they are literally, anticipatory grieving. They are in the moment of grieving. And so to bring something hard, I'm amazed with your jobs, so, it's easier when you do community counseling, in that way, it's easier to do community counseling because we get the caregivers, that are beginning to caregive. And so that conversation makes it easier because we're talking about, down the line. The other part that one of the things that I have heard from many, many clients that have been through the hospice program is nobody ever said the word death and nobody used the word dying. If I had known that my husband was dying, one woman came and she said, they keep talking about imminent, and she thought it was about the singer, but they were talking about imminent. And so we are so afraid to use those words because we want to hurt people's feelings. But I think that we need to be clear in our delivery.
I think that's a really good point, Vilma. We become used to using language, medical jargon, professional language that we understand, but we throw it out to patients and families and they don't necessarily understand it. And they feel, sheepish about saying, hey, I didn't understand what you just said. And so I think it's really important to us that's another way that we can be compassionate and considerate in these conversations, is to try to the best of our ability to avoid language that's confusing, professional jargon that avoid the assumption that they understand what those things are.
Things that are not clear and maybe dragging. Going back to what Dr. Jerez-Marte said, how much does the patient want to know? I think if we are sitting with someone that continues to ask the same questions or the same question in a different way, it might be a sign that the way we have explained it or tiptoe around it is not communicating the message. And at the end, is going to hurt the outcome. It's not going to provide the right thing.
So an example of that, Maria,
Go
I
ahead.
had a friend of mine whose father was having a pulmonary crisis, and they were wanting to intubate him, put a tube down his throat to help him breathe. And his two adult children were in the room, and one of them said, "Hey, Dad, you want them to do everything they can to help you breathe, okay, right? I can see you're really struggling. You want them to do everything they can to help you breathe, okay, right?" And so he said, "Yeah." And so he went to tell the doctor that he wanted to be intubated. And his other adult child said, "Wait a minute. So here's what they're going to do." And he described the process of what was going to happen. And their father already knew that he was in the end stages of his illness. And when he heard what really was going to be involved, he said, "Absolutely not."
Mm-hmm.
So the difference in how this information is presented really, it ends up being whether or not we even have informed consent to provide care.
Mm-hmm. And I hear from this conversation, and this is part of a project that we conducted in 2021, I believe, the Project Talk, or the Conversation Project. Some of the key components with research that Penn State College of Medicine was conducting, and we were one of the cohorts that hosted an event here, was sometimes we tiptoe around something. We use this verbiage, we avoid the conversation because we haven't asked ourselves those questions. We haven't had the conversation with ourselves. So if we haven't had that moment with ourselves, let alone having a conversation with others, we often leave it to the older and the sick when things can happen. I also hear a lot of the conversation with Vilma, Dr. Hernandez, regarding siblings. So, Jim, I don't know if you would like to bring up and talk a little bit about how sad and really concerning are some of the cases that we hear in our bioethics committee. Because at the moment that a case gets to that level is because these conversations didn't take place, or they might have taken place, but with people that were not in any type of document to honor our decisions. So I don't know if you want to briefly talk about the bioethics committee and their role.
That's another excellent point, Maria, because you're so right. Usually by the time a patient and family situation comes to the attention of the bioethics committee, the family and the patient are struggling with what the right thing to do is about their care. And they haven't had these conversations, and passions are running high. And it may be that the daughter feels strongly that the patient should have this done, and the son feels strongly that the patient shouldn't have it done. And then to Dr. Jerez-Marte's point, who is it that is ultimately the decision maker in the family? So often with hospice care, there does come a time when the patient's ability to clearly deliberate about all of the ramifications of their healthcare decisions begins to wane. And eventually they may lose that capacity entirely. And if they haven't had these conversations, then that opens up a whole other issue. Well, who is going to make the decisions? And when you don't have those decisions in advance, you have to rely on the Florida statute, which is put into place to try to protect the autonomy of the patient, but is imperfect because it can't capture the unique situation that every family has. Who is it that's been most involved in their loved one's care? Who is it that will stand by their loved one's profession, their loved one's desires about what they truly want done at the end of their lives? And so avoiding these conversations and not having them creates many, many scenarios where loving people struggle with each other about what the right thing to do is.
Thank you, Jim. And going back to the conversation project, as I became a big fan, sometimes we might feel that this conversation, again, lots of different holidays for different faiths are happening right now. You go to the stores and it's holy jolly, we have to be happy because it's the season, and but this is also about celebrating life. And the more we come to terms with how fragile we are, that today is the day we have, every day is a gift, the more we live our life to the fullest. Some people might perceive it that way. Some people might perceive it, these are difficult conversations. But allow me on a second to go back to the conversation project and a little bit of what Vilma was talking about. Sometimes it's going back to basics. I think sometimes we jump so quickly into very clinical terminology. We start talking about, my dear loved one, what would you like at end of life care? What do you think of respirators? Sometimes it's about simple things. So I always talk about visitors. I have made a list, handwritten, for my husband to show. If something was to happen to me and I badly injured in an accident or very ill, no one is going to label him the unfriendly, Matt is no being nice, he's the bad guy. No, I wrote down who I want to visit. I'm very fortunate. I have a lot of friends. I know a lot of people. But if I am in a situation like that, I want to keep it as private as a gift to my family and the very close friends of mine. So sometimes I start with conversations about visitors or conversations about socks. Don't put socks on my feet. I will never sleep with socks. Guys, I tell my family, if I'm ever in a situation that I cannot tell you and you think I'm cold, put 10 blankets on, put a heating pad, but don't put socks on me. I hate socks when I'm in bed. Sometimes by simplifying little things, then I can get into other things that are a bit more intimidating, But at the end of the day, I feel that we all have these conversations at some point. October, November comes, most employers are sending us what? Open enrollment. And here we are, we're like, yes, I want this life insurance. Let me increase it. What about health insurance? What about if something happens? But like Vilma said, we're talking about it, but we're not talking about it. So I wanted to ask a question to any of our panelists who would like to add to this. As a society, tell me, what can we do in our day-to-day life, meeting with family, clients, people that we serve? How can we little by little normalize conversations that are just so universal? This is the universal human experience. How can we little by little, one conversation at a time, begin normalizing these conversations?
I want to answer something quickly because I think as a society, if we, in every agency, in every public library, we have those forms available. We have them visible for people to pick up a form and ask a question. Also, we should do it in colleges. I don't know why we're not out there in, college when, people have accidents all the time, So I think that we need to start earlier, as a society, in the macro level, on putting it out there, on being able to talk about, geez, you're 22. What if something happens? Well, who would you like to make decisions for you? What would you like to happen? And people do respond. I mean, college kids do respond to those, like, oh my God, no, I don't want my mom to decide, blah, 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 blah. Then we're able to, leave it out there so that, but as a micro level, if every agency, every social services agency, just like we talk about a dentist and we talk about flossing and we talk about, teeth cleaning, we should really talk about this as a society. Leaving it out there, everybody should have a medical surrogate. Everybody should have, a living will. And so that's, my answer to that, in a macro level.
I remember one of the American, the HAPCM meeting, just for short, there was a talk with a palliative care physician, an interior designer, and a journalist. And they were discussing how to redesign the process of death. And, they talk about how death is viewed around the world in different cultures, the experience of celebrating, when somebody is passing, celebrating their life and how joyous it can be versus how, gray and intimidating it can be and sad. And so it's a tough thing to do, right? Especially when in your society, you have it labeled a certain way with zero effort or conscious effort, right, to change that, because that's how it is. And the way I see, piggybacking in Dr. Hernandez's, recommendations, is how about this is a little bit more embedded into the law or into infrastructures of how do we educate our children, perhaps starting at college level, right, and so forth. So, being responsible for dictating up front how they want to be cared for if they were to be in a critical situation or close to death or if facing death. And then normalizing those conversations in an environment that is not stressful, because we're talking here about difficult and courageous conversations because they're happening the very last minute. And we're here like a fire hose trying to just mitigate a horrible situation. But what if these conversations are happening at a completely different environment where people feel more comfortable, where people can ask questions, where they don't have to make the decision right at the moment? I think it would definitely change the way we see it, the way we prepare for that. There are things that I just learned the other day. I didn't know, and this is learned through a friend who has a disabled child. And because of custody of she had to become her own son's guardian, so that somebody else randomly, since her son is an adult now, doesn't come and then takes over the guardianship of her son. I mean, there's so much that we could learn and be educated about in these situations. So I think it would take also a state level, a government level, a federal level, to change a little bit more how these conversations happen. And then, perhaps that permeates through the culture and the society, and it's not such a taboo to talk about death. It may take years, many, many years. Maybe we would not be here when that happens, but somewhere we can start.
Thank
So,
you.
The story of the Buddha, Siddhartha Gautama, he led this really protected life where he wasn't allowed to see anything bad that happened because his parents really wanted him to grow up to be a king, and that one of the people predicted that he was going to be a great spiritual leader. They didn't want that to happen, so they protected him, made sure he didn't see anything bad. And the experience that prompted him to engage in his pursuit of enlightenment was he snuck out, and he had what they call the 3 auspicious sights. He saw somebody who was old, he saw somebody who was very sick, and he saw a dead body. And those things prompted him to reflect deeply about his own mortality, and that led him to his experience of pursuing and achieving enlightenment. And we live in a culture that not only denies death, but distances us from it. You know, funeral homes were called funeral parlors for a while because it used to be that there was a room in the house called the parlor, where if someone in your family died, that's where they were laid to rest, you know, and prior to the burial. But increasingly now, we've distanced ourselves from death. People are not having funerals and memorial services at all when their loved one dies, more and more and more. And so if we distance ourselves from it and we don't allow ourselves to come to terms with someone else's sickness, old age, and death, then we can keep those realities in our own life at bay as well. And so I know this is kind of a spiritualization of the issue, but I do think that we need to expose ourselves more to the reality of our own mortality, and that will prompt us not only to live our own lives well, but to prepare for peaceful end-of-life closure.
And for a good today. That also prepares us for a good today. I always reflect on the book by Dr. Ira Byock, you know, only when we learn to consistently say those things, you know, thank you, I love you, forgive me, and I forgive you, is when we will be ready, whenever the time comes, to say goodbye, because we have fulfilled all those things that are important to human life and human connection. Thank you, Jim, Dr. Jerez-Marte, Dr. Hernandez. I wanted to just read a couple lines from a very insightful conversation that we had pre this webinar. One thing was understanding that sometimes we're not going to have answers, and our presence for those that we serve, for those that we love, will be enough. So coming to terms with that is super important, coming to terms with silence. And Jim, you mentioned something on that meeting that really stuck with me, because again, some things even in one family, like Dr. Jerez-Marte was saying, and Dr. Hernandez, one family, my mom had only 3 kids. My brother saw her illness one way, I saw it one way, my sister another way. Everybody will have a perspective, one family. So, and we were talking about healing and hoping for cure or hoping for this. And you said this, hope and healing aren't denial. It is a sign of faith. And that will forever live in my heart. So I want to say thank you for that. So with that, I want to thank you again, our panelists, but I would like to open to comments or questions from people that were able to join today. You can unmute yourself, or you can put your question in the chat and I read it to our panelists. You see, we have comments. Special word from SAPTA. Every situation is unique. Yeah, thank you. Yes, Vivian mentioned very insightful conversation. Thank you, Erica, very helpful. So we have a question from Teresa. When making a list of visitors and last wishes, does this need to be legally created? So let's put a little plug on this. So Teresa, we are available, no group is too small. We can deepen the conversation about what can go in a living will. Florida does not require notarization. If you're a person that travels a lot and you spend months or weeks out of your year in other places, or you're thinking of loved ones, you can inquire about the requirements of all those places, or you can notarize the format that we use. You will see the format that we use at Empath Health, very similar to the one used by Baker Hospitals. It has a lot of input from healthcare providers, because sounded like at some point lawyers and doctors were not communicating well. So the format that we use have a space where we can write things free writing, free speech to our loved ones. And the good thing is it can be revoked once we write a new one. It can be modified. So guess what? If at some point I feel like, it's okay, we can have everybody come into the house, I can modify that. It's a
And
beauty.
that's important, Maria, that you mentioned that in the
Yeah.
state of Florida, it doesn't have to be notarized, because I think it's something that holds people back to fill
Mhm.
out a living will, because they think that they need to go in front of a lawyer or a notary, and it makes it so convoluted and complicated, and it takes time. And it's not. You just have to get the form, fill it out, sign it. Obviously, we advise that whoever you choose as healthcare surrogate, that are aware of, because we've had a few surprises for people that were not even aware that they were the healthcare surrogate. But surprisingly enough, you don't even need to have that person sign the form. So it can be somebody out of state. You don't need to be mailing forms to anybody. It's very simple. It's so
Yeah.
simple that you can get it done in 5 minutes. But highly recommend, if you haven't done one, to just go ahead and do it.
Yes. Thank you, Dr. Jerez-Marte. And I see a question from Maribel Raudales asking if you can have a copy of the form. Absolutely. Through, I believe you are part of the advisory council for Josie Flores. She can send you one, bring you one, but anyone can go on empathhealth.org, and under our services, you will look for advanced care planning. So let me put it on the chat. So again, empathhealth.org. And once you go on our website, through all our services, you can look for advanced care planning. You have material there. You have informational sheets about all these different terms that we throw, CPR, DNR, what they really are, and how to sometimes, if we get comfortable with these terms ourselves and have the conversation with ourselves, then when we sit with our physicians, guess what? The conversation is going to be a little lighter, because now our physician is going to be like, okay, it's safe to have this conversation with this person because they have done already a little bit of research. They're
Maria,
humans too.
You brought something up too that I think it's important to say too. It might not be a one and done scenario of doing your advanced directives too. Usually they say we should remember the 4 Ds for advanced directive. You should review your advanced directives if a decade has passed, if you are divorced, if you get a diagnosis, or if you experience significant decline. Any one of those 4 reasons, take another look at your advanced directives, because depending on those circumstances, your wishes may have changed. And that's what it's all about, right? It's about making sure your wishes are known and respected when you're no longer able to speak them for yourself.
Absolutely. And thank you, Jim. And I find the power of revocability of an old advanced care planning document, living will, or designation of healthcare surrogate very empowering. Knowing that I can always change my mind depending on the circumstances. Sometimes it's a huge change because of a change or advancing science. So that's good to know. So Kelly Garrett, our community partnership specialist for the Sarasota area, she put the full link to access our advanced care planning documents and information on our website. Again, we're very thankful and appreciative that you spent this evening with us. We will be sending the link to our community council, advisory councils, and please know that we are one phone call away, one email away, and we can bring this information to any groups. No group is too small. Thank you so much, and you have a beautiful evening.